Hi, everybody. Welcome to Meet Our Advisors, a new blog series at Not Putting on a Shirt, where we talk with our medical and legislative advisors about who they are and how they came to be on our council and support our work. So today we're talking to Dr. Minas Chrysopoulo of PRMA, that's plastic, reconstructive, and microsurgery in San Antonio, Texas. He's a board-certified plastic surgeon specializing in breast reconstruction, autologous breast reconstruction. He's authored several articles and book chapters, and all around a very busy and accomplished guy. So thank you, Dr. Chrysopoulo, for joining us, and I'm really happy to talk to you tonight about this important topic. We'll jump right in with our first question. Why don't you tell us about your work and how aesthetic flat closure came across your radar screen?
Oh yeah, sure. So that's a great question. So our practice primarily deals with breast reconstruction. Over the last, it hasn't actually been that long, but over the last few years, a handful of years, I've definitely had an uptick in patients coming to discuss what they described as cleaning up. So these were patients who had visited with their breast surgeons, gone through mastectomy. At the time, breast reconstruction maybe was discussed. In certain instances, it wasn't even offered, but many times it was discussed and was offered. And these ladies that were coming to me now after the fact without reconstruction, there was a mixed bag, really. Some ladies were very decisive and had decided for sure they didn't want reconstruction, but because that decision hadn't been made before the mastectomy, they had extra tissue that had been left behind. Really, there wasn't that much discussion, if any, or effort to really make the chest wall truly flat in terms of the contour after the mastectomy. There was oftentimes this sentiment of, oh, well, we'll leave you some extra tissue in case you want reconstruction, in case you want to be reconstructed later. Sometimes we even had patients that were upset because they were definitive. They knew from the beginning that they didn't want reconstruction, but that choice was kind of dismissed a little bit, and the breast surgeons went ahead and left the extra tissue just in case they changed their mind. So that's how it came across my radar. Patients were coming specifically not for breast reconstruction, but they, through research, realized that a plastic surgeon was the person to see to rearrange tissue or fix contouring issues of the chest. So really, it was patients requesting it. That's how it came on my radar. It was a definite departure to what my practice has been used to in terms of the phone calls we were getting. It involved re-educating my front desk staff, because before it was very much, well, what do you mean you want to come in and see us if you don't want breast reconstruction? So it's been a good educational and growth experience. I feel badly that patients find it so hard to get in to see the right person. Sometimes it's still an ongoing issue, but I'm excited to be part of the conversation and try and fix that and increase the awareness about chest wall reconstruction. I'm not really so much involved with the initial mastectomy. My involvement tends to be after the fact for women who didn't really get the truly flat closure that they had expressed that they had wanted. So long-winded answer, but that's how I got into it. The techniques that we use to rearrange tissue are all plastic surgery techniques. So it's really right up our alley, really, in terms of our skill set.
Yeah, and I want to remind everybody watching, plastic surgeons are trained specifically in aesthetics, to pay attention to the aesthetics. And that's not always true for breast surgeons, right?
Right. So I think we have a good opportunity to, within the training of breast surgeons, really make them more familiar with the plastic surgical techniques that can be incorporated at the same time as a mastectomy closure. But you're absolutely right. It's, we have to realize, I think, collectively, all of us involved in this effort, that just because a patient requests a flat closure, it doesn't necessarily mean that the breast surgeon involved in the patient's care truly knows how to give them that. A lot depends on body habitus, how much tissue we're dealing with, the size of the breast, lots of factors, really. But I think we definitely have an opportunity here in terms of training and increasing the scope of training of our breast surgeons as they come through, so that we get to a point where a plastic surgeon doesn't need to be involved for an aesthetic flat closure, ideally.
Yeah, that's great. And it's great that you went over this with your front desk staff, because what I've encountered talking to a lot of different people is when people call about a revision surgery, which I think is what you're talking about, most of your flat patients going flat are there for revision to improve the contour. A lot of times that they get put off, and it's not that the front desk staff is trying to be rude or doesn't want to see them. It's just they're not familiar with it. And so I think it's important you're the president of PRMA, you set the tone, right?
That's important. Right. That's right. Yeah, that's absolutely right. And especially, all practices strive to be efficient. And so we all have our protocols. And so, if something doesn't fit into a box, the front desk, it's not out of malice or being mean. It's just, they don't, honestly, a lot of people answering the phone when patients call any practice, they may be reaching a person who doesn't really even understand what the patient's talking about, right? So
yeah, and it's important that everyone be on the same page, because the patient calling doesn't really have much experience with it either.
No, well, that's exactly right. That's exactly right. And actually, some patients kind of snuck through, as it were, because they said, "Oh, I just want Dr. Chrysopoulo to take a look and give me his advice." And then it was for a revision of a chest contour, so to truly create the flat profile, and moving tissue around, fat injections, fat grafting, that sort of thing. But had a patient said, "Oh, I don't want breast reconstruction," and maybe she would have met some resistance in getting in. That's been fixed, thankfully, a long time ago now, because we're very familiar with it now. But at the beginning, it was certainly a re-education.
Yeah, for sure.
Yeah.
So we've been talking about revision surgery. So this is, again, after the initial mastectomy, after you've healed from that, if you're unhappy with your contour, you would seek out usually a plastic surgeon to get this revision surgery to improve the contour, make you more comfortable. But for patients who are facing initial mastectomy, I know this is not your specialty, but patients who've been diagnosed with breast cancer or have the BRCA gene or another gene that puts them at higher risk, if they're considering going flat, just globally, what advice would you give to those patients, or what should those patients know going into it, in your mind?
They really have to force the conversation with their breast surgeon to understand that they're being heard. Even in our breast cancer conference here locally, some of our breast surgeons are truly on the same page, and they truly get what aesthetic flat closure means, but other surgeons can't even wrap their head around it, and so it's all about, they're focusing on what they deem the priority, which for someone with a breast cancer diagnosis, obviously it's the mastectomy, it's, life before breast or life before, chest contour, and some of them have had a tough time adjusting to the fact that aesthetic flat closure is actually it's a thing, it's a real entity. In fact, it just came up the other day in our breast cancer conference, and right after the conference, I had 3 patients refer to me because the breast surgeons had heard the complaints from their patients about the extra tissue left behind, and they didn't know what to do about it. And so these surgeons thanked me for bringing it up because they had no idea that this was a real option. So, oh, you mean you guys can help us out even if the patient doesn't want breast reconstruction? Like, absolutely we can, send them over. So the education is constant, you know. It's not out of malice that patients aren't ending up getting what they want. This is mostly, I'm convinced, an education issue, a training issue. You know, it's not, I haven't personally in our community, I haven't come across the earlier example I gave of, you know, someone not being heard, or, you know, oh, I told them I wanted to go flat, but they ignored me in case I wanted to have breast recon later. That actually hasn't happened in our community. I've heard that from people outside of our community traveling to PRMA. I haven't heard that within our community, thankfully. I don't know if it's happened or not, but I haven't come across any examples.
Yeah. What we saw in the survey that we did, which again was just ad hoc, you know, survey, it was about 1 in 20 patients going flat. Now that may be overshot. I don't know. I'm really looking forward to seeing more solid research on that with a larger sample.
So 1 in 20 were not heard. They had expressed their preference to go to have an aesthetic flat closure, and they weren't.
Yeah, 1 in 20 were agreed on a flat closure, and the surgeon indicated that I left a little extra in case you change your mind. And it's for the people that got the poor aesthetic result for other reasons that weren't clearly intentional, it was like another 2 or 3 out of 20.
Yeah. Sometimes, you know, the surgeon is going to try their best to leave the patient flat, but sometimes they need a revision anyway, right? Then that's to do with, again, so you know, surgical factors, anatomic factors. Sometimes you want to, you know, you need to pull the tissue a little tighter so that they end up truly flat, but the blood supply to the tissues that are left behind aren't the best, and so the surgeon may be worried about wound healing. You know, so sometimes it's also a safety issue. You know, even if someone you know, wants a specific result, it doesn't mean that they weren't heard, but we definitely do a better job of listening as a specialist.
Yeah, for sure. It's not usually intentional, and the data reflects that. It's important to keep that in mind because most surgeons are in it to help patients. I mean, that's why you become a physician to help people.
Yeah, I mean, and unfortunately, it's the nature of the beast. Surgery, you know, I think I'm a great surgeon, but not everything works out the way I intended it to work out, right? We have substandard results, unfortunately. We all have complications. Anyone who doesn't has either never operated, is delusional, or is lying. Right? So, you know, we all have to get our patients through that. Unfortunately, that's part of it. So,
well, and that brings us to shared decision making, because a big part of the shared decision making model is setting realistic expectations. And I think for a patient who hears the word realistic expectations, they think, oh no, maybe they're not going to do a nice job for me, but it's really a matter of making sure that your surgeon understands what you want, and that they understand what you want, and that you understand what is reasonable to expect, so that you don't wake up to something that's totally different, you know, out of the blue.
Exactly. And what could happen that would end up with you not getting what you've discussed, but that's part of the shared decision-making conversation, right? You know, shared decision-making, as you know, it's a topic that's kind of close to my heart. You know, you've worked with me on the Breast Advocate app. It's all about shared decision-making.
Oh yeah, you should tell us more about that app. I forgot to mention that in the intro.
Well, yeah. So it's got a great aesthetic flat closure section, thanks to all your help. So I really appreciate it. So shared decision making, you know, it's not a new concept. It's been around since the 80s. Unfortunately, it's standard of care, but it's not standard practice. And shared decision, a lot of that is that it's really misdefined or it's misperceived. A lot of physicians think that shared decision-making simply means telling someone about the potential complications that can happen. That's only part of the conversation, right? And so when you talk about whether or not to leave extra tissue or not, because the patient either has decided to forego reconstruction or they're undecided about reconstruction. And so there's the choice, there's the pathway that the surgeon can go down. Even if the patient decides that they want to have a completely flat contour, they need to understand what that decision in and of itself means. So it doesn't mean that they're one and done and necessarily, and that they may not need further surgery, because even ladies deciding to go completely flat and go with the aesthetic flat closure, a lot of them may need a tune-up. They may have a contour issue, they may need some fat injection still, they may still be left with extra tissue because of tension and not being wise with the blood supply to the tissues. All this is part of the shared decision-making conversation, but it's a lot more than just potential complications, right? And so a physician trying to understand the patient's preferences, if that physician leaves extra tissue in case the patient changes their mind, by definition, they haven't had a shared decision-making conversation, because shared decision-making involves the patient giving the information they provide is their preferences, their goals, their choices, the reasons why. So if you understand that and the patient knows they don't want reconstruction, why would you even think about leaving extra tissue just in case? Mm-hmm. So unfortunately, shared decision-making takes a little bit more time usually, and patients need to be able to push their preferences and have the right conversation. And that's why the Breast Advocate app was created, and that's for all breast cancer surgery options. I'm obviously a breast reconstruction guy, but the app focuses on all options: lumpectomy, oncoplastic, mastectomy, aesthetic flat closure, and all the types of breast recon for anyone who's had a breast cancer diagnosis or is at high risk of developing cancer because of a gene mutation or strong family history. So very comprehensive. So free download, here's a shameless plug, free download at breastadvocateapp.com, and it's got a great aesthetic flat closure section.
It does. And I also want to say the decision wizard was really helpful, and I felt it was really well designed. So it asks some questions about how important is X, Y, Z to you, and you can say, and then it will help you, guide you to make a decision that is in alignment with your values and your priorities. And so it's a good tool to use in advance of your consult, I feel like, or maybe afterwards to help you think through. So yeah, highly recommend.
Thank you. Yeah. We've had great feedback, and it's been helpful, both before to get an idea of what's important for you to talk about as a patient, and then also afterwards to kind of recap. Mm-hmm. So yeah.
Yeah. So to wrap up, I know we're getting short on time now. I guess we covered some of this earlier, but are there any other important issues surrounding aesthetic flat closure advocacy that you would like to see us focus on or see as part of the discussion generally?
I think, you and I have had a side conversation about insurance before. I think that's something that we've got to stay on top of to make sure surgeons know how to code appropriately, and really for them to know that there are codes that can be used very appropriately for the techniques that we use for aesthetic flat closure. So we're not reinventing the wheel. We don't need new codes. We already have the codes that we need. We just need to educate them in terms of which codes are appropriate. So that's good news. The codes are already there. So it's a hell of a lot easier than trying to make new codes, right? So, I think
I was just going to say, you can find all that on our provider resources page on the website.
Yeah, that's a great addition. So great work. Love what you're doing. Thank you for advocating for our patients. Awesome job. And I'm honored to be involved.
Thank you so much. And thank you for all that you do for patients. It's so important. And, hearing you speak about it, I think it's really impactful, not just for the patients, but also for any providers that might be interested in learning more about the issues surrounding aesthetic flat closure. It's helpful to hear from other professionals. So I really appreciate it. Thank you so much.
You're more than welcome. Take care.
To learn more about the Breast Advocate or to download the app, go to breastadvocateapp.com. Thanks for watching. Learn more at the website at notputtingonashirt.org, or find us on Facebook or Instagram at notputtingonashirt, or on Twitter at not_shirt, or send us an email, info@notputtingonashirt.org.